Welcome to NAIOP Solution Series program titled Healthcare Capital Markets Update. My name is Sandy Hudson. The Solution Series programs are available at no cost to NAIOP members. These mini webinars run less than 30 minutes, and our goal is to provide you with some quick tips and insights, all types of strategies and tactics to help you succeed in today's business environment. Do you have a suggestion for a topic? Please email us at solutions@naiop.org to let us know what topics you would like to hear about in future programs. Please advance to the next slide. NAIOP has produced the popular Solution Series programs for 3 years. Did you miss one of our informative topics? The archives of these programs are available to NAIOP members at no cost through the on-demand bookstore. Examples of past programs are listed on the current slide. Our topics cover niche development, finance, marketing, and more. Visit the NAIOP website at www.naiop.org/Solution Series for links to the archives. Please advance to the next slide. And now let's get on with our program. With us today are Bodnar and Lee Asher, co-leaders of CBRE's National Healthcare Capital Markets Group. This group specializes in providing healthcare real estate investors with acquisition, disposition, and recapitalization strategies, assisting healthcare providers with strategic capital planning, and advising health systems and physician groups in the developer selection process. Disciplined in the specialty of investment sales, Chris has been involved in the disposition of over 4 million square feet of commercial assets, exceeding a total value of $1 billion on behalf of its clients. A 22-year real estate veteran, Lee has assisted on transactions involving all investment property classes, ranging from $1 billion portfolios to $1 million single property assets. Welcome, Chris and Lee. Thanks for being with us today.
Well, thank you, Sandy. Before we dive into the presentation here, just a quick slide with a background on our group. As Sandy mentioned, Lee and I are primarily focused on the single asset and portfolio monetizations for investors, developers, and health systems. The core product type that we focus on is medical buildings, but we also have significant experience in monetizing higher acuity facilities, such as surgery centers, long-term acute care hospitals, rehab hospitals, and psychiatric hospitals. But for the purpose of this presentation, we are going to provide a broad overview of the healthcare industry and then tie it back into both opportunities and challenges available in the healthcare real estate sector. So it's really 4 topics we want to go over today. I'm going to start off talking about one of the biggest trends facing the industry: consolidation and integration.
And this is Lee, and I will be discussing healthcare and retail and who's doing it and why.
And then we'll switch back over to me to discuss healthcare in politics, specifically what's been happening at the Supreme Court level.
And after that, I'll give an update on the healthcare capital markets and give you a glimpse into our recent investor survey.
And then we'll just finish it off with the crystal ball and provide an outlook for the rest of the year going into 2013. So with that, let's just dive into it. In order for us to really understand the opportunities in today's healthcare real estate market, we believe that it makes sense to first take a step back and understand the state of the industry. This slide gives you an idea of really all the capital pressures facing health systems in today's market. Starting with limited philanthropic resources, diminished investment returns, electronic health records and coding requirements, aging infrastructure, physician employment, continued economic uncertainties, increasingly competitive markets, and then finally at the top of the slide is pending reimbursement cuts. And really, I think that last point, the pending reimbursement cuts, is probably the biggest pressure point for health systems, and it hasn't gone unnoticed by the rating agencies, as you'll see in this next slide. So both Moody's and Standard & Poor's currently have a negative outlook on the healthcare sector because of revenue pressures. And really, the fact of the matter is that our country is significantly over-leveraged, and the rating agencies have obviously recognized it with S&P's downgrade last year. And this has put a lot of pressure to make budget cuts. And the area with the biggest target for budget cuts is the entitlement programs, which include Medicare and Medicaid. And as we see declining reimbursements from the government payers, it's only natural that we'll see the commercial payers, the Cignas, the Aetnas, the Blue Cross Blue Shields of the world look to do the same. So sounds like a lot of doom and gloom, but I want you to stick with me here. There's a lot of opportunity that's going to come out of this on the real estate side, which Lee and I will get into a little later. So with all these capital pressures, how are hospital systems reacting? Well, they need to achieve economies of scale and better negotiate their position with insurance companies, which gets us to the consolidation side. So this slide shows us how the healthcare industry stacks up with other industries from a market share perspective. And if you take the retail pharmacy business as an example, and you'll see on the right-hand side of the graph there that the top 5 retail pharmacy companies make up almost a 70% market share. And it really wasn't that long ago when pharmacies were operated by mom and pops at the corner drugstore. However, the industry experienced significant consolidation due to decreased margins as a result of increased regulation and lower reimbursement rates set by both private and government payers. So the result is that we have a large grouping of retail pharmacy companies, the CVS's, the Walgreens, the Rite Aids, who started off big and became even bigger because their scale allowed them to better negotiate terms with insurance companies. Now, if you look at the hospital side, on the far left-hand side of this graph, there are about 5,800 hospitals in the United States. You'll see that only the top 5 only take 11.5% market share. So what's the conclusion of this slide? Well, health systems have to go in the same direction as the retail pharmacy business in order to better negotiate reimbursement rates, and they need to do that with scale. And with that comes consolidation. So where does the government want health care? Well, they want full integration. And full integration can be accomplished in several ways. One way is with the Kaiser model of vertically integrated organization where Kaiser basically owns the insurance company, the hospital, and the physician groups. Another example of full integration is through the accountable care model, which is part of the recent legislation that was passed through. An accountable care organization model is basically linking reimbursements to patient outcomes as opposed to fee-for-service. And they do this by integrating physicians with hospitals and the insurance company. And one of the better examples of this is a pilot program that Dignity Health, which is formerly Catholic Healthcare West, did in Sacramento. And CalPERS, the California State Pension Fund, placed over 40,000 of its members in this accountable care organism through Blue Shield's HMO program. And Blue Shield of California is in partnership with Dignity Health and a primary care physician group as part of the state. And by integrating all 3 of these services, the physicians, the insurer, and the hospital, the group was able to create a 50% reduction in the number of patients hospitalized for 20 days or more, a 17% reduction in hospital readmissions, a 14% reduction in total inpatient days, and a half-day reduction in average length inpatient hospital stay. So what is motivating this group? Well, it's the savings that's created by coordinating this care. This particular ACO is expected to save about $15.5 million, which then gets passed back to the group as a whole. So each one of the components of the ACO, the physicians, the insurer, the hospital, they're all incentivized to provide better outcomes for patients, not a certain number of procedures. You'll see here, this is all the savings that was incurred at the group. Another way to integrate is through the employment model. And as you'll see at the top of this slide, a quote by Managed Care magazine, which reads, "Late this decade, the majority, if not 85 to 90% of all physicians will be integrated into some type of system. The kind of practice of preventive medicine we once knew is dead." And really the main reason this is happening is that physicians are also facing decreasing margins like the hospitals. And operating as a standalone practice has become more difficult than ever before. Also, students are coming out of med school with more debt than we've ever seen, and they just can't take the risk of starting their own practice anymore. They want to come out of med school with a steady paycheck, have someone cover their overhead, including malpractice insurance, and they really want the ability to schedule their own hours. So if you looked at the way physicians were set up 10 years ago, then employment really wasn't there. And physicians were mostly had on-staff privileges at several competing hospitals, and most of the hospitals try to lure these doctors to occupy their on-campus medical buildings so that those physicians were more likely to refer patients into the hospital for inpatient procedures. But as more and more docs become employed, these docs are actually required to refer to the systems because they're employed by the system. And this has given the hospitals a lot of flexibility. The hospitals don't necessarily need to keep these physicians on campus, specifically the primary care doctors, and they have looked to decompress their campus and deploy these physicians into new communities to capture greater market share. And this really leads into our next topic.
Thanks, Chris. And this is Lee Asher. Regarding healthcare and retail, another big trend in addition to consolidation and integration that we're seeing in the industry. And one of the things that's happening, the slide in front of you shows you who is doing this, who's moving out into the retail environment, and it's sort of a who's who of healthcare. You've got Emory, Dignity Health that Chris had mentioned used to be Catholic Healthcare West, Cleveland Clinic, Baylor, Catholic Health East, Vanderbilt, and all of these folks are moving out into the retail space. So why are they doing it? Well, the retail setting allows, and go ahead to the next slide, Chris, the retail setting allows the healthcare providers to move off campus and closer to the neighborhoods and rooftops, which is where their patient base lives. Now, to capture market share, one way a group like Emory is positioning to capture more market share is via their alliance with CVS. Now, this is just one example of an increasing number of partnerships between health systems and retailers that we're seeing in the marketplace. One aspect worth noting is Emory's goal here is not just to capture market share by teaming with CVS. It's also to keep people healthier and out of the hospital. These Emory staff mimic clinics bring more customers inside the doors of CVS, which is great for CVS, but they also benefit Emory by creating an easier and more affordable access to care for non-emergencies, which by default can reduce costly, unnecessary hospital ER visits. And that's a huge savings for Emory. Now, the other reason they're moving into the retail environment is for billboard-like branding. Retail, by its nature, offers storefront signage and also monument signage, and that's welcome advertising in this really highly competitive space we are with healthcare systems. There's also large parking ratios in a retail environment, and they've also started offering valet service. So when you're on a hospital campus, you have to navigate a maze of parking decks, and that can be a challenge, particularly for the elderly, to park and then make their way through elevators and across other crosswalks to get into the building. When you go into a retail setting, you can literally park in front of the entrance or toss your keys to the valet and walk right into your appointment. There's also, this feature of the parking also adds to patient convenience, and it's also with the amenities combined in the retail setting, the patients and their caretakers are able to run errands and do other things in the retail environment while their loved one is seeing their physician. So it's actually made it a lot simpler and easier to go to the doctor and, take care of some things while you're there. More foot traffic. It's interesting how you look at this because referrals in the healthcare setting typically comes from other physicians, you have one specialist or primary care doc referring to out to another physician. In a retail setting, you actually increase your odds of picking up a new patient referral, which could simply come from your neighbor, which might be a retail salon or the UPS store. Now, lastly and most importantly, the way the retail market has been hit in the recession has created some dark space in grocery-anchored centers as well as big boxes, and that's allowed some of these health systems with good credit to show up and come in and take space at a much lower occupancy cost. Now, one of the classic case studies of how this is happening is with Vanderbilt. In Nashville, Tennessee, Vanderbilt University Medical Center identified a 40-year-old mall. It was about 880,000 square feet, and they transformed that into a mixed-use environment where there were still retailers in the mall, but Vanderbilt came in and took about 450,000 square feet. Now, why did they move into the retail facility? Well, they did it for what we mentioned on the previous slide. It was to capture greater market share. They ended up with billboard-like branding because they had monument signage in front of the mall, and it also gave them highway exposure. And the old mall had large parking fields, which allowed for very convenient access, much different from their very compressed campus with the parking decks. They had retail amenities of the other retailers that were there, which increased patient convenience and foot traffic, and the occupancy costs were significantly lower than any of the rents that they may have had to pay on campus or in a newly developed medical office building near the campus. So the other thing that they created that Vanderbilt benefited from moving in this retail setting, taking on 450,000 square feet is a lot, and they consolidated a lot of different operations and a lot of different groups into one location. That created tremendous efficiencies. And as Chris mentioned with the consolidation and integration, that's the name of the game, is to create these efficiencies. Well, this environment allowed Vanderbilt to create those efficiencies. One place where we're not really seeing efficiencies in healthcare, though, unfortunately, is with the government. And so Chris is going to transition over to healthcare and politics for a little bit.
Yeah, Lee is right. Unfortunately, this cartoon that you'll see on this slide, I think says it best, highlighting some of the inefficiencies of our government as it relates to healthcare. And you heard in the news recently that the Supreme Court had an unprecedented 3-day series of hearings of arguments on the constitutionality of the Patient Protection and Affordable Care Act that was enacted into law in 2010. And most health systems have been going in the direction of assuming that law is going to be fully implemented by 2014. But now with this Supreme Court hearing and ruling hanging out there, there's definitely scrutiny on the mandate on whether the government can force its citizens to purchase health care insurance. And the question really becomes, if the Supreme Court determines that that portion of the legislation is unconstitutional, do they just remove that portion of the legislation, or does the entire legislation get struck down? I think Lee and I could go back and forth politically and speculate where it might go, but I think the key question to ask is, how are investors reacting? And the fact of the matter is that investors aren't waiting on the Supreme Court ruling. Investors have gotten into the healthcare space because of the demographic trends, not the legislation. And the legislation itself is not reforming the delivery of healthcare; it's reforming healthcare insurance. We also think that, regardless of what happens at the Supreme Court level, there are some popular provisions in the legislation that we still think will be implemented one way or another. The pre-existing conditions, coverage of adult children, the accountable care organizations that we referenced earlier. Another component to this as to why investors are moving full steam ahead is just the fact that reimbursements are going to continue to decline for health systems whether or not this legislation gets pushed through. And this forces hospitals to grow quicker in an outpatient and ambulatory setting. By growing in an outpatient setting, it's a lower cost for the provider to occupy. It's a lower cost for the provider to develop, and it's actually cheaper for the patient. So outpatient healthcare is not going away, and that's definitely benefited the real estate market. And then finally, the last point on this slide is that investors have been very disciplined in their acquisitions. They have not been buying medical buildings based on the potential outcome of reform. And if they had been doing that, they would have likely been looking at lower demographic areas, as those are the areas where there's a lower percentage of the population that's insured, and that will likely benefit the most out of the legislation. We haven't seen investors buying in lower demographic markets. They are, like I said before, very disciplined, looking for strong demographics, a population that currently has a high percent insurance percentage, wealthy and affluent population. Those things are still being looked at very under a microscope by investors, and that's not going away. So you look at where the activity has been. Lee's going to talk a little bit about historically, where volume has been and where trades have been, and then we're going to kind of take a look at where we might be heading.
Thanks, Chris. So here is a quick summary on healthcare capital market trends. This slide you see in front of you depicts the MOB annual sales volume and cap rates. And as you can see, annual sales volume in 2011, which is on the far right in the lime green, is down compared to 2010. But it's a little bit deceiving, because the numbers for 2010 actually include Ventas's acquisition of Lillibridge in all of their assets. But if you remove that, we're looking at similar numbers to last year in 2010 that we saw in 2011. Now, even so, 2011 was about half of what we saw at the peak in 2007, as you see in the middle of the chart. That's also when cap rates were at their lowest. We saw cap rates drop a little bit from 2010, as you can see, to 2011, and we actually anticipate further cap rate compression coming into 2012. Now, on the next slide, one of the things that we are able to do when we evaluate the market is we run a medical office investor developer survey, and that's where we poll the market and talk to the leaders out there and get a sense of where they see trends in healthcare. And our 2012 survey actually had a really good balance of respondents. No one investor category made up more than 32% of the result set, and all of the respondents included healthcare REITs, private capital, institutional healthcare investors, and healthcare real estate developers. So one of the questions that we ask these respondents are about return requirements. So the slide in front of you now is showing return requirements for Class A medical office building. Now, the chart above, the dark green represents 2011 survey results, and the lime green is for 2012. One of the key questions in our survey we asked is, what will the cap rate be for Class A on-campus and off-campus MOBs? The Class A on-campus product type is continuing to be priced most aggressively, and it has arguably surpassed the previous peak in the market that was set in 2007. Now, as you look at the top graph for the Class A on-campus, 50% of our survey respondents indicated that a market cap rate for Class A on-campus product would be below 7%. And when you look at that graph, that's a big increase over the previous year. In addition, 41% of the survey respondents indicated that a market cap rate for Class A off-campus product would be below 7.5%. Now, that compares to last year when only 20% of the respondents believed that off-campus would trade at a sub 7.5%. So, we attribute this trend to two things in particular. One is hospitals and their good credit have been moving off-campus into the outpatient setting. And with that it sort of enhances the Class A off-campus tenant profile and tenant mix because you've got the stability and the creditworthiness of the hospital system. The second reason we're seeing cap rate compression is institutional investors are allocating more of their core funds to the healthcare sector than we've ever seen in years past. Now, going to the next slide, we asked the same question for Class B product for both on and off-campus medical office buildings. So, Chris, if you'll advance the slide. Okay, so same scenario, dark green is 2011, lime green is 2012. So for Class B on-campus medical office buildings, they're priced a little less aggressively than the Class A off-campus product type, and you see at the right there at the 7 to 7.5% mark, 24% of the survey respondents indicated that market cap rates for Class B on-campus product would be below 7.5%. Now, this is only a slight increase over the previous year, but the attraction for on-campus is still there, or at least for investors that are willing to pay for it, with 45% of them predicting the cap rates will be between 7.5% and 8% for on-campus product. Now, Class B off-campus on the lower portion of the graph, that's probably priced at the least aggressive levels, and we had 49% of the survey respondents indicating that a market cap rate for this product would be below 8.5%. Now, either way, it's a substantial change over the previous year when only 34% of the survey respondents indicated that a cap rate would for Class B off-campus would be below 8.5%. So these survey results, even though we're through the first quarter of 2012, they're pretty consistent with what we've seen year to date. And basically, cap rates for on and off-campus product is lower across the board, and we're seeing aggressive pricing, especially for core products. Now, we prepared another slide here to show the risk frontier for the going-in yields for medical office buildings. And so to help kind of put the whole cap rate results of our survey into perspective, this slide here will illustrate that, you know, for Class A and B on and off-campus product, and we included one that was adjacent to, which is the blue in blue, and Chris will have to advance the slide a little bit to show the Sacramento deal. I'll hold on a sec. There we go. Okay, so down there in the bottom of blue, the Alhambra MOB in Sacramento, that was a off-campus but adjacent to, it was adjacent to the campus. So the idea here is that Class A on-campus product obviously has the lowest perceived risk and therefore the lowest cap rate. So as you go on the left side and down into the corner, you see the Doctors Community Hospital MOB that sold for $23 million in June was in a low 6 cap rate range. Now as you move off campus into Class B product, the perceived risk increases and the cap rate gets higher. Now the trade range for these deals that we're showing you here, they range from $6 million to $100 million, with cap rates varying from low 6s to high 9s. And the interesting thing about this is the buyer set for these assets, for all of these, it includes a mix of both public and private REITs, institutional healthcare investors, and private capital. And you know, one of the factors that we think is influencing cap rates is supply and demand. Now, we're currently in an environment where demand clearly outweighs the supply. It's a market condition that was confirmed in our survey as well as what we're seeing in the market. And in the graph above on the right-hand side where you see demand in lime green, 61% of our respondents, so roughly 2/3, predict that demand will be higher in 2012 than in the previous year. And on the left-hand side with supply, 58% believe in the dark green that supply will be the same as 2011. Now remember from our previous slide when we talked about transaction volume, 2011 only did about $2.5 billion in transaction volume. Now it's not really surprising to us to see this, and it's consistent with recent market activity. But one interesting development that we're seeing here this year is what's happening with financing and fundraising among the REITs. And in the first quarter of 2012, which just ended, REITs that invest in healthcare have raised more than $6 billion. That's $6 billion. So that's more than double the 2011 transaction volume. Now, granted, some of these proceeds will be used to pay down debt, but a large portion of this we think will fuel demand for medical office product, of which there's clearly a limited supply. Now, to add fuel to the fire, besides the public REITs and the private REITs that have raised $6 billion, we know of at least 6 new funds that have formed that have over $1 billion in purchasing power, and they'll be focused on healthcare real estate as well. So, what's the outlook on what we think is going to happen for the balance of 2012 and 2013? Well, if we were to look in our crystal ball here, I think there's a couple things that are happening. One is the new capital that I just mentioned. Now, this is pension fund money and offshore equity, and these new entrants are going to help set pricing. They're getting aggressive. They need to pick some trophy assets for their fund as the first assets that are going to go in there, so they're going to be very selective, and I think they're going to push pricing up a little bit. We're also consistent with their required product type. We're going to see a real strong market here for well-occupied, well-contemplated, stabilized medical properties. And we also think an interesting trend that we haven't seen in years past, with all the consolidation among health systems, there's also some consolidation among the REITs, and we think some of the REITs are going to start to take some of their chips off the table for the non-strategic assets. And when I say non-strategic assets, what I mean is if they've got a single-tenant medical office building that doesn't generate any management fees or leasing fees, they may choose to dispose of it. Or, based on the consolidation and integration in the industry among health systems, they may, by default, inherit or acquire or have an asset within their portfolio suddenly be a part of a system that it wasn't previously that is competing with one of their other clients in their portfolio, so they may need to dispose of that asset. And Chris, you can talk about the remaining bullets there.
Yeah, investors, we also think are going to look closer at the floor plans in the older medical buildings, as that's where the majority of the independent practices are located. These independent practices are typically anywhere between 800 to 2,000 square feet, and as these independent practices consolidate with other practices or get employed by the health system, we do think we're going to see larger spaces, likely averaging between 6,000 to 8,000 square feet. As more physicians get employed, we also see that this is going to benefit the investment community, as these medical buildings are now going to get a credit in name. Even though S&P and Moody's do have a negative outlook on the sector, the credit that's behind a hospital is substantially stronger than what you'll get even with personal guarantee by a group of physicians. And then finally, the last bullet point here goes back to what I wrote as what might be that as doom and gloom within the industry itself, with more pressures on revenues for health systems than ever before. We think that's created substantial opportunity on the real estate side. Health systems are going to be looking for experts to help them operate their real estate, and in some occasions own their real estate. And they're beginning to realize that real estate makes up a substantial portion of their balance sheet, anywhere 40 to 50% of the assets on the balance sheet itself. So that's our crystal ball, Sandy. We appreciate the opportunity, and if anybody has questions, please have them contact us at the email addresses here.
Chris and Lee, thanks for a great presentation and discussing the healthcare industry and the opportunities in today's market for medical office buildings. Our next Solution Series program on how retail development in Canada differs from the American models will be available on May 8th. Watch your email for NAIOP source or corporate e-newsletter for the program link. Thank you for listening to our session and have a good day.